So we have a lot to talk about. And for those of you that have seen, I'm Ed Weisbart. I'm a family physician. I'm on the national board. I chair the Missouri chapter. And I spent 7.5 years as the chief medical officer of Express Scripts, plunging as deeply into the dark side of the force as you can. And so this is part of my atonement tour, as our friend Wendell occasionally would say. So we have a lot to talk about. And for those of you that have seen talks about Medicare Advantage before, there will be some overlap for a little bit from this morning, but not very much. I took some of those out this afternoon. And the ones where there is overlap, we'll be talking about things from a somewhat different point of view. And my point of today is that there are things we can say to our patients, to our colleague physicians, and to legislators that I think are increasingly persuasive. So that's my goal for today, is to arm you with that and to give you perhaps specific steps that maybe we should be thinking about taking along that road. So that's kind of my goal. And to get there, we're going to walk through some information, and just in the spirit of things, of course, late yesterday, Ron Wyden released a whole bunch of new information. So some of that's in here too, but not as much as you might want. So this is a huge issue for all of us. To start, here's something that we all probably have watched happening. We know that Medicare Advantage is now essentially taking over Medicare. The reason I wanted to repeat this data point for you, that I know you know, is because of how legislators interpret this. So when we talk to legislators about our concerns about Medicare Advantage, one of the first things they say is that patients love it. Look at how much it's growing. So they say that, they say this specifically. Here's a letter from a strong majority of people in Congress, bipartisan, that said older adults on Medicare Advantage report consistent satisfaction with their coverage and quality. In other words, they could have said this: the market has spoken and Medicare Advantage is growing because it's better and seniors love it. That's, honest to Pete, what a lot of legislators will tell you. Not all, but a lot. And I think, one of my heroes is Don Berwick. I don't know if you're familiar with him. He's a huge former administrator of CMS. Am I doing okay on where I am? What's wrong? So sometimes if you just mention Don Berwick, things start to go haywire. Let me turn off my phone. There we go. So former administrator of CMS, and he made a pretty good comment, I thought, about why Medicare Advantage is so popular. He said, if an ice cream firm can offer ice cream for free because of a subsidy, its market share will, of course, grow against firms that charge for ice cream. It's not because of it's better ice cream, it's because it's free ice cream. And that's, of course, what we need to bear in mind. Medicare Advantage isn't growing because it's better, and I'll show you some information about that. It's because of the incredible subsidies that we're, in my mind, wasting our time on. And as you know, we're also wasting our money. So, here's the overhead of traditional Medicare, depending on what year and what exact way you look at it. It hovers around 2%. And you have to add in profits if you want to look at the commercial insurance industry, of course, and with them, it comes up to a much higher number, which is money, of course, that's not spent on actual healthcare. What about clinical outcomes? We saw one study that Adam presented this morning, and that's about it that I know of for suggestions of quality outcomes. For the most part, there really isn't any solid research comparing clinical outcomes. So we know we're spending more, and there's not much outcomes data. And the reason for that is because Medicare Advantage so infrequently releases any meaningful outcomes data. Medicare doesn't have the ability, I guess, to compel that. And so we see Medicare Advantage or MedPAC reports over and over again saying, we don't have the data. We can't actually give this analysis to you. So let's spend a moment sort of defining what Medicare Advantage is, just so we're all on the same page. Here's traditional Medicare. As you know, it's simple and efficient and operates, as we said, with about a 2% overhead. And it's almost as simple as this cartoon, although we know that there's some pieces of it that aren't really that simple now, but it's almost, I thought I turned it off. Let me really turn it off. Sorry. My lack of iPhone skills. So that's that traditional Medicare, essentially. Medicare Advantage, as I think we saw a little bit in the slide this morning from Dan, is almost the same, except that it's completely different. Instead, we impose insurance companies in between Medicare. We still pay our taxes, Medicare, that still happens. And then Medicare Advantage introduces these commercial insurance products. So Medicare has to have a contract with each one of them. There's complexity and expense in that. And then each one of them has to have a contract with medical groups, doctors and pharmacists, and hospitals, and I guess not pharmacists so much, but all over the place. And it's even more complicated than that, because it's not, you can go to anybody, it's, we like this doctor, we don't like that doctor. So this huge complexity, and of course there's gaps in there. So Medicare Advantage is fundamentally complicated. There is no real guardrail you can put around it. There is no way you can really improve it to be anything near what we want from traditional Medicare or from Medicare for all. So Medicare Advantage, unlike traditional Medicare, Medicare Advantage makes heavy use of the tools of managed care. So, as we're going to come to at the end, messaging to physicians, when physicians are distraught, as we all are, when we have to deal with prior authorizations and step therapy, and we experience that through our Medicare patients, it's incumbent on us to make sure that they understand that that's their Medicare Advantage patients, and to point out, and they may not always see it, depending on how their office is set up, that it's Medicare Advantage that does those things. It's not traditional Medicare. And it's, Medicare Advantage, as we know, has these crazy networks, as I kind of cartooned you. Traditional Medicare doesn't do that hardly at all. 89% of adult medicine physicians accept traditional Medicare. 96% of surgeons accept traditional Medicare as a payment model, according to a June 2022 survey. So no commercial insurance company offers a network like that. And as we know, and I'm not going to belabor, the business model that Medicare Advantage, like other commercial insurance products, is to essentially avoid sick people and try to attract the healthy. High overhead, we talked about a moment, and I'm not going to unpack most of that in any detail, because there's lots of other places where we've done that, including today a bit. But I am going to unpack this a bit more. The accusations of fraud that are so rampant in the Medicare Advantage companies. So we saw this get above the fold recently when the New York Times, there was a huge article on Sunday a few weeks ago. You should know that PNHP had a large voice in getting that to happen, actually. So just lightning round through it. All the time we see accusations of fraud. Here's an OIG audit, and I'm pointing this out to say this isn't some fly-by-night group auditing it. This is the Office of the Inspector General auditing Humana in Florida, and found that they were being overcharged by nearly $200 million through upcoding and such. And indeed, the recommendation to repay, according to OIG, this would be by far the largest audit penalty ever imposed. And notice it's not yet resolved, even though it was audited then. Sutter settled for $90 million for knowingly submitting fraudulent diagnoses. And they're kind of striking if you look at these, what this audit showed. It said the diagnoses of fractures, 66% of the times that MA plans said there were fractures, that was fraudulent. I imagine sometimes it was completely fabricated. Most of the time it was, well, he broke his wrist when he was 16 and now he's 70, so that's still a medical problem, and we need to upcode, we need to include that code. 90% of the cancer 90% of the cancer diagnoses, according to this audit, were like that, and even more for strokes. Again, most of them were kind of remote events. So if this one gets settled, it will be, oh no, it was settled, I'm sorry, when this one was settled, it was the largest false claim act ever settled. Now, the reason I'm bringing this one up is because it's sort of a typical example of the fact that it was settled, right? It was settled. So that means that Sutter never admitted, perhaps they were really not guilty, but they were never really admitted or convicted of fraud. Turns out to be important that they settled and were never actually convicted. So there's lots of these. We saw this morning, I think Daniel showed the slide of this, which I'm going to kind of just make a little prettier, but the same data. Many of them have been accused of fraud. My point to bringing it back to you is that these accusations of fraud are again from really credible sources. So here it's being accused of being a fraud by a whistleblower, and what is that, 6 of them, 5 of them that of these top 10 accusations of fraud by the United States government. Even more have been accused of fraud by the United States government, not by Bobby in St. Louis, but by the fraud by the United States government and overbilled according to the U.S. Attorney Inspector General. So this is a big deal. But my point of this little revisiting of this question is that accusations, settlements, penalties, and fines are not as potent as would be convictions. And convictions can justify excluding you. Convictions for fraud can justify excluding you from the MA, from any federal program, Medicare or Medicaid. And hence, we're always seeing this. They settled for $90 million, but there's no admission of guilt. So I don't think that's a coincidence. So let's make sure we're all on the same page about risk scores, and we're not going to do kind of the deep dive into the numbers on risk scores as we've done, as I've done in the past, and as we saw a little bit from Daniel this morning, but just a little bit so we understand how this even exists and why it's such an easily gamed problem. What are these risk scores? The risk score is what determines how much the Medicare Advantage plan is paid per person. So if you have a higher risk score, then the Medicare Advantage plan is paid more for you. And if you're like 0 risk scores, then they're paid less. And the risk scores are technically called the hierarchical condition category. Technical phrase is the hierarchical condition category. And we're not going to unpack that more, but we could if you want. So HCAs or HCCs, those are the same things when we say risk scores. And they're based on a variety of things, but one of those is diagnosis codes. And that's really important when you think about how diagnosis codes are established and how things are paid for. So in traditional Medicare, physicians are paid by, we're all physicians are largely, we're paid by CPT codes, by procedural codes, right? The 99215s or what have you. So we're paid by procedure codes, not by diagnosis codes generally. So we make sure that we have enough whatever to document to get up to the highest procedure code. And we don't, in the traditional Medicare, there's no financial incentive to do, to capture useless, needless, irrelevant, off-topic diagnostic codes. But Medicare Advantage is paid the opposite. They're not paid by CPTs, they're paid by ICD-10s. So they have a game to maximize the number of ICD-10s that they can reimburse. And we saw from Daniel this morning sort of a dollar amount of what that upcoding looks like. The point of this is that they've gotten really good at that, since that's where the money is. The ratio of coding intensity versus demographic analysis has been skyrocketing in Medicare Advantage. And that's not because people in Medicare Advantage have been getting sicker. Indeed, there's really no difference in the health status from over this time period. So the diagnostic codes are getting more intense, but the patients are not getting sicker. And in fact, these unsupported diagnoses are a major part of the overpayments in Medicare Advantage. And now we see that the numbers are still skyrocketing up, not going down. You would say, well, Medicare Advantage is paying for itself, right? Because it's saving all this money. Kaiser family recently said, once again, their Medicare Advantage has never generated savings relative to traditional Medicare. And in fact, they don't generate savings. The opposite is true. And that's indeed what these bar charts show you, is every year since at least 2008 in this data point, they have not been making savings. They've been getting more. And as we saw from Daniel, it dwarfs budgets. Medicare Advantage overbilling, and that's just one piece of how they get more money. Medicare Advantage overbilling dwarfs all of these. So, where do we want to spend our money? Not there, if you ask me. So they create their, so Medicare has coverage rules, all right? If you're in traditional Medicare, there are rules about what's covered, what's not covered. There are rules about what's paid and what's not paid. And I think of this a little bit like national cancer guidelines, where there are broad guidelines. But any individual plan can narrow. You can drive a truck through cancer guidelines. There's a lot of space in there. There's a lot of space in Medicare, traditional Medicare coverage rules too. And Medicare Advantage plans are allowed to create their own proprietary guidelines. I think of them as double secret guidelines. You can't get them, they don't typically share them, they don't post them, but they're allowed to create their own proprietary coverage rules. And as a consequence of that, denials of prior authorization requests by Medicare Advantage plans, denials of prior authorization requests by Medicare Advantage plans that met Medicare coverage rules, 13% of their denials actually met Medicare Advantage coverage rules. And denials of payments was actually as high as 18%. So these plans are able to create and protect privately their own secret coverage rules that are not contained in the Medicare coverage rules. And that's part of why you run into all these speed bumps in Medicare Advantage that we don't usually run into in traditional Medicare. And this really hurts our patients, as we know. So the percentage with cost-related problems accessing care in traditional Medicare, it's not zero, it's real, but it's much higher in Medicare Advantage. Good news for the white folks here, it's less if you're white. If you're Hispanic, it's worse, and if you're Black, it's horrible. So if you look at these numbers, traditional Medicare folks with Medigap, Black folks with Medicare and Medigap, 20% of them have trouble accessing care, whereas white folks who are in Medicare Advantage have a lower number. So, the racial disparities here are just one of a gazillion examples we could have, and these numbers are even more striking for people who are in poor health if you select for that. And the people who are in Medicare Advantage because of their coverage rules don't go to the premier hospitals as often. This is really important. If you've had cancer when you have cancer in your patients, you try to send them to the place that you kind of think they should go to. But when it's in your family, there's like no room for negotiating. When somebody in your family gets something, you want to do your own searching, you want to figure out where you want them to go, and you want to go to the best place that there is. And if you have Medicare Advantage, you're not as likely to be able to do that. And it's not for everything. For an appendectomy, probably, surgeons at most hospitals can probably do that well. But if you need some of these procedures, you don't want to have someone else tell you that you can't go to those places. So significantly fewer procedures. And I'm particularly dismayed by the number on the Whipple procedure. When I was in med school, we were taught, try not to do that procedure. It's too dangerous. So you really want to go to somebody who has experience with it. And so as a consequence of this, people, when they're really sick, they try to leave Medicare. And so before the final year of life, less than 2% of people try a switch back from Medicare Advantage and traditional Medicare. And during the final year of life, people are more inclined to do that. And the reason is because they have difficulty accessing the specialized care that we know they need, that they know they need. So I don't know if you have met our PNHP board member, Jessica Shore-Sachs, but she had a terrific column in the Charlotte Observer, I think it is, recently, about a month ago or so. And she said, so if it's so bad, why are people picking Medicare Advantage? And we're going to try to unpack that quite a bit more, because I think we all need to understand that. She said, despite all these problems, Dr. Sachs said, the low premiums and perks may still be attractive to seniors who are not yet sick. But the situation often changes when they develop an illness, as we were starting to see. So what I'd like to do is, for a moment, is unpack the difference between traditional Medicare and Medicare Advantage. I'm not sure that some of our key groups, legislators and patients particularly, understand it. So traditional Medicare, 40% of them have picked traditional Medicare because they wanted that choice of doctors and hospitals. 40% of people in traditional Medicare picked it for that reason. 24% of people in Medicare Advantage picked Medicare Advantage because they wanted more benefits. And they liked that idea of an out-of-pocket limit. So they're making the choice for that. 9% of Medicare, traditional Medicare people picked it because they were recommended to go into traditional Medicare by trusted people. And I think that's what happened with my sister-in-law about a month ago. I guided her into traditional Medicare for that kind of reason. But interestingly, 15% of people, more people, pick Medicare Advantage because they've been guided into it by trusted people. Some people are in traditional Medicare because they kind of had to be in there. They've got these sort of resources. And 11% likewise in an employer. A tiny percentage understand the financial impact of traditional Medicare versus Medicare Advantage, and they pick traditional Medicare for that reason, and a few people pick Medicare Advantage for the other. But the thing I'd like to point out to you is some are picking Medicare Advantage because we're recommending it. We physicians are recommending it to our people, to our patients. So we know traditional Medicare is imperfect. As you know, in traditional Medicare, there's a 20% co-insurance, and I know you know what co-insurance is. There's a 2023, the hospital deductible is going up from $1,550 or so to $1,600, and there's still no out-of-pocket limits. So these prices can become pretty unaffordable. And then you've got to deal with premiums for Part B, of course, Part D, and you probably would want to try to buy a Medigap plan. And we're going to talk about that in some excruciating detail in a moment. Not excruciating, you'll like that. It'll be fun. So they have three options. You can stay in traditional Medicare and not go into Medigap. And if you do that, as I just alluded to, you're exposed to bankruptcy. The out-of-pocket costs have no limit. So if you don't get a Medigap plan and you're in traditional Medicare, and about 10% of people, I think, in Medicare are in this situation. You can instead choose to get out of traditional Medicare and go into Medicare Advantage, as we've been unpacking, or you can stay in traditional Medicare and purchase Medigap. But there are some really important things about Medigap that are not widely understood, and that's one of the reasons was so eager to talk about this whole topic with you. You might be able to go into Medigap. So what does that mean? Well, let's compare Medicare Part G, or a Medigap plan. I'm using Part G or Plan G as an example, because that's really the most sensible choice these days. Plan F was better, but you can't join that anymore. It's closed to new enrollments. So let's look at Medigap Plan G versus Medicare Advantage. There's a premium to purchase a Medigap policy, and I think the average is around $200 a month. Then there's, but if you do that, then there is nothing out of pocket after you've gotten past the fairly modest deductible, $226 deductible in 2023. So you pay a premium, but then there's no out-of-pocket expense as long as you stay within traditional Medicare, which is almost everywhere. Medigap policies do not expand the benefit design. So Medigap policies, Plan G, for example, does not include dentistry or optometry or hearing aids. It's just fixing the copays and deductibles. But the Medigap also has no impact on the network. So if you're in traditional Medicare and you do the smart thing and buy a supplemental policy if you can afford one, if you do that, then, or you get it through another source, if you do that, then you still have the full traditional Medicare network. And you don't get exposed to all the utilization management shenanigans that happen in Medicare Advantage. So Medigap plans do not add step therapy or prior authorization. That doesn't do that. Just deals with the copays and deductibles. Medicare Advantage, on the other hand, I mean, I think 69% is the number I saw. 69% of people in Medicare Advantage pay no premium. I could have done that when I retired. They pay no premium to be in Medicare Advantage. The people who do pay a premium, the other 31%, the premium average is around $56 for them this year. But the average, if you look at all the comers in Medicare Advantage, the average is an $18 premium per month compared to around $200 for a Plan G. There is an out-of-pocket network with a limit, which can be varied somewhat by plans, but the combined out-of-pocket network, out-of-pocket expense for people using in-network and out-of-network is more than $12,000. So yes, there's a limit, but not a terribly good limit. And it's smaller if you stay in-network. And some plans have lower out-of-pocket limits. As we know, Medicare Advantage can add in extra perks, extra things, but they have, the whole network issue becomes a point. And Medicare Advantage, as I've said twice now, and I'll say it probably once more, introduces all of the utilization management things that we all are so distraught over in commercial insurance. So those things exist in Medicare Advantage. They're really common in Medicare Advantage, and they're virtually non-existent in traditional Medicare. But the reason people make this decision, typically, as I showed you, is because it's almost free. It's almost free. So, sorry. So most people in this situation have maybe heard some of the stuff that we just said about networks and prior authorizations and all of that stuff, but they're looking at $200 versus $18. And so what they think they'll do, and here's the flaw that I really want to make sure we all understand, what they think they'll do is, I'm healthy. I'm going to be healthy for a while. I don't care. When I'll save the money, and when I'll go into Medicare Advantage, I'll pay them their much more modest premium. And if I get sick and I'm unhappy about it, I can always switch back. I can always switch back to traditional Medicare. And that's all over the Medicare Advantage materials. If you want to get out of Medicare Advantage, you can do that whenever you want, not to worry. But what they don't tell you is that you would be getting out and may or may not be able to buy a Medigap policy, because there's a trap that most people making this decision don't know. And so they don't know the trade-off that they're making. So the Affordable Care Act introduced two really important, we all know the pros and cons of the ACA, and I'm not here to relitigate that question, but there are two really important protections to commercial insurance that we now take for granted, but that people don't realize are not in Medicare. Those protections, those consumer protections, those patient protections are not in, the ACA did not extend them to Medigap. So the first one is, it's called guaranteed issue. So this means that for the first 6 months, federal law is that for the first 6 months that you're in Medicare Part B, any Medigap plan that you apply to is guaranteed to sell you a policy. So if you're, for the first 6 months that you're in Medicare Part B, a Medicare Gap insurance company must sell you a policy if you ask for it. They can't send you the health survey questionnaires. They can't say, oh, you've got the cancer, we're not letting you in. They have to let you in. And that disappears after 6 months. After 6 months in Medicare Part B, suddenly the insurance companies, when you apply for one, are absolutely allowed to send you health survey questionnaires and decide whether you're too sick or healthy to sell you a policy. That 6 month period is extended to 12 months. Guaranteed issue goes to 12 months as a trial period for you if you go into Medicare Advantage. So once you're in Medicare Advantage for 12 months and a day, if then you get something where you want a disease, where you want to go out of network, or you want to, whatever, you're tired of, you run into step therapy or some prior authorization that's not giving you what you need, at 12 months and a day, you decide you want to get out of Medicare Advantage and go back to traditional Medicare, you can do that, but you might find that you can't buy a Medigap policy, and therefore your exposure to bankruptcy for leaving that becomes outrageous. And then parallel to guaranteed issue is, what price do they sell it to you at? And this is the same. That's called community rating, meaning that, again, the insurance companies have to sell you their Medigap policy at the same price they would sell to anybody in your community, without asking you the health survey questionnaires. After 6 months in Medicare Part B or 12 months in Medicare Advantage, that disappears. And then all of a sudden, not only can they say no to you because you're too sick, but they can say, oh, and by the way, your premium, you've got that disease, your premium is going to be outrageously expensive. And so people I don't think widely recognize that and don't realize the trap that they're letting themselves up to. So how do you fix that? where do you advocate for that? Well, it'd be great to just fix that federally, but Medigap policies, it turns out, are regulated at the state level. So if you're looking for something, what can our chapter organize around? This might be one of them. I mean, I don't know that this is the right one to pick, but it's one of the things that that can be regulated by states. And in fact, 4 states have guaranteed issues. So meaning anybody can get Medigap anytime that they apply. They don't have to, the 6 to 12 month period disappears. So Connecticut, Massachusetts, New York, and with a little more caveats on it, the state of Maine. So states can do this. I believe these states did this a long, long time ago. I don't believe a state has actually made this change in the last many years. And likewise, there are states, more states, those 4 plus 4 more, that have community rating in Medigap policies. So there's the list for you to read. So I had this slide talk all cooked. I spent like, I don't know, quite a bit of time trying to prepare what I'm going to talk about. And then Daniel talked about a lot of it, so I changed my slides. And yesterday, just to make it even more fun as a speaker, Senator Wyden's healthcare or Senate Committee on Healthcare on Finance released this massive new report, which I'd recommend you look at if you haven't seen it. Have you seen this report? Yeah. Yes. Yeah. There you go. Yeah. It's what? Mike is saying that with one click politics has been bugging Senator Wyden to release this report, and indeed they did yesterday. So I have not done a deep dive into it, but I found some things I thought were kind of interesting and fun that I thought I'd show you. I've never seen this before. So the report documents tons of fraudulent marketing and advertising. And here's sort of one fun little example. There's a Medicare bus, MedicareBus.com. So it drives around, I guess, and it exists today. And I saw this last night, and I went to MedicareBus.com, and it takes you to a commercial insurance broker. It doesn't take you to Medicare. More, little maybe less amusing. I found that that's my sense of humor. I found that funny. Perhaps a little bit less amusing is this report from Senator Wyden shows this. That some of the Medicare Advantage companies are sending out these mailers that look like they're federal tax documents. I mean, that looks like a federal tax document. So it gets your attention, and this is actually working. It turns out seniors are starting to notice this. Seniors are starting to notice these misleading ads, the Joe Namath ads, which have been changed a little bit, but they're the Joe Namath ads and all these other things. Seniors are noticing this more than they ever have, and complaints to Medicare, to CMS, about misleading or plain false advertising has been going up quite a bit in the last 2 years. And that's in part because these ads and marketing materials have gotten way worse in the last few years. The Trump administration undid some of the regulations on this and some of the supervisions on this. So the ads, as bad as they were 10 years ago and 5 years ago, the last few years are even more egregious. I see this as an opportunity for us. I see President Trump's having dismantled some of the protections, as limited as we all have our concerns about Medicare Advantage. I'm right there. But now it's becoming obvious to people, and I see that as an opportunity. The primary source of these complaints are from the things you would think, from mail advertisement, from television advertising, from the telemarketers. Some robocalls will call you. In the report, they said there are some robocalls coming in. One robocaller making 20 calls per day to prospective members. I mean, it's, we can't use our phones anymore. That was probably Medicare Advantage calling me. My phone went off a moment ago. So how is this happening? It's happening in part because that's where the money, we told you how that's where the money is, but a lot of people turn to an insurance broker for guidance about what to do. Hey, I'm 65 now. What do I do about my Medicare? Do I get, do I do one of these? What do I do? And this is new information actually, that Medicare Advantage pays when a broker enrolls you in Medicare Advantage, they get a pretty dramatic commission. They get a pretty dramatic commission, and their commission for enrolling you in Medigap is smaller and getting smaller, so that the brokers are very conflicted on this. Little bits on Part D, but that's why a lot of brokers won't even talk to you about Part D. They'll just tell you to go to Medicare.gov because there's not enough money and that to spend the time on it. But there's this conflict here. And understand, once they get you in, once a broker signs you up for Medicare Advantage, if you don't change brokers, or if you don't change Medicare Advantage plans, the broker gets that commission every year for 10 years. The commission gets a bit smaller. In the out years, it's about half the size of the initial commission, but they keep getting, it's the gift that keeps giving. So there's a lot of money in it for these brokers. And CMS actually did a secret shopper process on looking at what insurance agents say. And it turns out, according to CMS's secret shopper call, 80%, 80%, you know, when you see those numbers in medicine, I mean, I translate that to 100%, you know, but 80% of calls were inaccurate or insufficient in what they led. So one example, I thought this was sort of struck home with me. If your medication is not on formulary, just tell your doctor. The doctor will tell the plan and the plan will just put it on the formulary. I'm not making this up, and this isn't from, you know, a fringe, this is from CMS. This is a CMS secret shopper type thing. So what do we do about this? That's been kind of a recurrent theme, and I've tried in the last chunk of time to sort of arm us with the information, somewhat overlapping with what with Daniel and Adam's terrific talks were, but I tried to fill in where I think we need to add more parts. So I want to propose 3 key messages, one each for 3 key audiences. So first, for patients, what do you say? And these aren't, you know, cast in stone. This isn't like, you know, I don't have evidence that these are the right things to say. I just sort of, you know, when I'm doing it, I think this makes a lot of sense. So the first thing is that most patients don't understand that $200 trade-off against the $18 trade-off, they don't understand all of the rest of the financial implications of that decision. And now, not everybody can obviously afford to buy a Medigap plan, and that's why we see so much Medicare Advantage penetration among certain populations. But if you can afford it, you know, that they need to at least understand, people need to at least understand the decision that they're making. They need to understand that they're not just kind of, you know, you know, when you hear something crazy, kind of going, what? And scratch your head. No, there's compelling evidence from Medicare that many of the promotions are deceptive, fraud, and predatory. So why doesn't Medicare fix that? Why do they let this go on? Well, actually, there has been significant progress over the last 2 years under the Biden administration on some of this. You know, it's still Medicare Advantage with all the fundamental flaws that can't be fixed, but there's that. And the thing that seniors really need to understand, that our patients really need to understand, is this issue of you may not be able to buy a Medigap policy if you've been 12 months in Medicare Advantage. I promise you, 95% of people making that decision have no idea about this fact. So if there's one thing you want to tell people when they're thinking, hey doc, should I do a Medigap or should I do Medicare Advantage? That would be the one thing that I would really focus on. When you're talking to physicians, I hope this isn't insulting, but they need to understand that Medicare Advantage is not traditional Medicare. They're not the same things. And they really need to understand that when we're talking about Medicare for all, we are not talking about Medicare Advantage with all of its things, and we're not even talking about current iteration of Medicare. You know, there's no physician in practice who won't bemoan, you know, all the crazy reimbursement models that CMMI and others have been imposing upon us. They know that, and so so it's become harder to say we want traditional Medicare, not Medicare Advantage. So they need to understand when we're saying improve Medicare for all, as I think Adam emphasized, that's some of the improved that we're talking about. That's some of the improved. So improved Medicare will have none of those nightmares. And in fact, that's not just sort of, you know, our pipe dream. Well, I guess it is still, but the language in the bills, in the House bill and in the Senate bill, specifically prohibit the use of prior authorization and step therapy. And I should caveat that I checked it in the House bill. I didn't double check it in the Senate bill, but I believe it's prohibited in the Senate bill too. So we are formally and explicitly proposing those programs be prohibited. The last thing that I would say to when we're talking to physicians is they'll probably, most doctors that I talk to bemoan these things with us. You know, they bemoan these problems with us. I'm not telling them any news that Medicare Advantage gets in the way of patient care. They know this, but what they don't realize is how incredibly potent their voice is. How incredibly potent their voices. Talk to their patients, you know, try to go to grand rounds and try to be able to talk about it there, you know, write those op-eds. You know, Jessica Zach said that, you know, her op-ed drew in a lot of new people who hadn't thought it through. George Bomfalk, you know, lots of examples of people hearing this from their colleagues and going, well, and then it getting through. So if they get this, they need to raise their voice, because really we are the only ones in the position to be seeing upfront and personal how this interferes directly with patient care, and not just in the way of, well, I didn't like that, but in the way of, no, this is really dangerous. This is what's happening. So we need to raise our collective voices. And if a doc says, yeah, I'm with you, ask that doc to, you know, to raise their voice. And lastly, my point would be to legislators, use that free ice cream metaphor. You know, it's, you know, because they will come back with you and say, hey, you know, shut up, doc. You know, it's so popular. It's growing by leaps and bounds. And use Don Berwick's, you know, quote him, you know, mention his name, because, you know, most legislators, since he was head of CMS for a while, know his name and respect him. And he wrote this. It's in public. There's a reference on the bottom of the slides that you look at. He published this, that no, it's not because Medicare Advantage is better. It's free ice cream. Everybody wants the free ice cream, you know. Why not? So second message, I think, is to make sure that to dispense that myth that Medicare Advantage is saving the country money. Dispense that myth. Ask them, why do you think that? A legislator says, well, you know, it's cheaper. Why do you think that? Help us understand that, because there is no database for that. And then lastly, what's really been resonating the last few weeks in probably more and more is the idea that it's fraud. You know, it's fraud. You know, fraud, it may not be the entire business model of Medicare Advantage, but it's really a common thing. You know, it's a really common thing. It's hard to make as much money off of Medicare Advantage as they want to if they don't do these fraudulent behaviors. So the very last piece I want to discuss is sort of, you know, how do we, a bit more about how do we get there? And I'd say, you know, of course, we want to get the bills passed. You know, we want the bill in the House and the Senate passed. You know, get your legislators to co-sponsor this. Of course, we want that. That's the core goal. But as our speaker about privatization mentioned, focus on the steps. You know, focus on the steps. And one of the problems is that the playing field between Medicare Advantage and traditional Medicare is profoundly unlevel. So the first thing is the improved part of improved Medicare for all. Let us try to get those bills passed, and let us simultaneously work on improving Medicare, eliminating copays and deductibles, or if we can't eliminate them, you know, create an out-of-pocket maximum. There's no out-of-pocket maximum. You know, eliminate the need basically for Medigap with its premiums that we have to pay for, and then make sure that the benefits in Medicare, in traditional Medicare, are as good, if not better, than the ones that Medicare Advantage is allowed to offer. So level the playing field by improving traditional Medicare, and expand those protections that the ACA has. You know, ACA protects you against pre-existing conditions. Well, you know, that should apply to Medigap. That should apply to Medigap too. So I think that's something that a narrow specific thing that could be focused on. And then strengthen the patient protections. You know, prohibit the use of these secret utilization rules. If they're going to put up a utilization rule, a prior, they should make that public. If they're so proud that these are evidence-based, robust, good rules, publish them. You know, let everybody see them, because you can stand behind them, right? There's evidence saying that that's medically sound. Publish them. Don't use secret rules. And if you're engaged in fraud, you should not be engaged in. We need to continue that push to try to get fraudulent companies out of this. So, how do you raise your voice? Very last thing is that the PNHP, lovely secondary website, protectmedicare.net. If you haven't seen it, that's where we've sort of housed a lot of our ACO REACH DCE stuff is on this protectmedicare.net. And soon, according to Dixon, within the next week or two, this protectmedicare.net is going to also have a robust set of resources about Medicare Advantage. So we're going to expand that goal. So protectmedicare.net.